Welcome back to Pathways in Paediatrics. This is the official podcast of the European Academy of Pediatric Societies, EAPS.
Indeed. And in our last few episodes, we've journeyed through some really key areas: ICU, respiratory, immunology, genetics, rare diseases.
Yeah, and oncology, long-term care, pediatric surgery, plus psychiatric and developmental health. Quite a range.
Absolutely. But today, we're focusing, sort of zeroing in on something truly fundamental: nutrition, obesity, and endocrinology.
This is a major theme for the upcoming EAPS 2025 Congress, isn't it? That's happening October 18th to 20th in Lisbon and also online.
Exactly. And it's such a critical area impacting almost everything in child health. So our mission today is really to give you, our listeners, a sneak peek.
A preview of some of the really cutting-edge talks you can expect from leading experts at the Congress.
We want to pull out those key insights, the things that might actually change how you approach cases day to day.
Okay, so where should we start? Pediatric obesity seems like a huge topic, a global challenge, really.
It is. And that's why we should probably begin with Patrick Tunian's talk from France. It's in the update on pediatric obesity session.
Okay.
He's going to be pushing for a significant reframing of how we think about it. He'll argue that we really need to move past seeing childhood obesity as simply, poor eating or lack of exercise.
Right, the sort of lifestyle choice argument. That's often the public perception.
It is, but Professor Tunian will stress that the science is pointing elsewhere. It's more fundamental.
Okay, so if it's not primarily lifestyle,
Yeah.
what is driving it, according to this emerging view?
The core argument is that in most cases, it stems from genetic programming. We're talking inherent variations in the hypothalamic pathways.
The brain's control center for weight, basically.
Exactly. These pathways regulate body weight, hunger, fullness, how energy is used. The idea is that the system itself is just programmed differently from the start in many kids who become obese.
So the genes are the blueprint, but the environment must play some role, surely. I mean, obesity rates have skyrocketed relatively recently.
Oh, absolutely. The environment is crucial, but its role is maybe different than we thought. Professor Tunian describes it as obesogenic, which is accurate.
Okay.
But he argues it's not the primary cause. It's more like the trigger or the enabler. It allows that underlying genetic predisposition to actually express itself, to become visible.
Like the seed and the soil analogy you sometimes hear. The genes are the seed, the environment is the soil allowing it to grow.
Precisely that. The modern environment, with easily available high-calorie food and reduced physical activity, lets that genetic potential flourish.
And if we accept that perspective, the implications are, well, they're pretty profound, aren't they? Especially for the kids and their families.
Huge. It could massively reduce the discrimination obese children face and alleviate so much of the guilt parents feel, which is often based on these widespread misconceptions.
Yeah, the blame game doesn't help anyone.
It doesn't. Understanding the biology helps us move away from blame towards, effective support and treatment. It allows clinicians to target the mechanism, not just lecture about willpower.
And we do have some handles on these mechanisms already, don't we? Like the melanocortin pathway.
Yes, that's probably our best understood example right now. That system is key for appetite and energy balance. And we know that mutations in specific genes involved there, like MC4R, POMC, leptin, are found in, maybe up to 15% of children with severe obesity.
So that's not insignificant.
Not at all. And knowing about these specific genetic factors is already leading to more targeted therapies. It's quite promising.
So this isn't just theoretical. We could be looking at real, durable treatments emerging in the coming years based on this genetic understanding.
Yeah, that's the hope, definitely. But Professor Tunian will likely also point out where the gaps are. We still need more research, especially on epigenetic fetal programming.
How the environment before birth might influence things.
Exactly. And also the role of the gut microbiota, the bacteria in our intestines. How does their composition play into this? These are big questions still.
Okay, that's a fascinating overview of the obesity reframing. It seems Professor Tunian is also speaking about another critical area in early nutrition.
Yes, he's also tackling cow's milk protein allergy, CMPA. That's in the morning rounds. Allergy in the newborn session. So we're shifting gears slightly to an acute issue right at the start of life.
CMPA. That can be really challenging for clinicians, especially with changing guidelines. What's the latest on the first-line approach if you suspect it? The elimination diet.
Right. Clarity here is key. The recommendation is very specific now. First choice should be either an extensively hydrolyzed cow's milk protein formula, that's the EHCF, or a hydrolyzed rice protein formula.
Okay, rice protein is explicitly mentioned as a first-line option alongside EHCF.
Yes, and importantly, the guidance is clear. Not a soy-based formula as a first step.
Why the caution against soy?
There's a higher risk of cross-reactivity, and clinically it often doesn't manage the non-IgE symptoms as well. The hydrolyzed rice protein formulas have shown good efficacy, comparable to EHCF, offering a non-cow's milk option right away.
And what about those amino acid-based formulas, the really broken down ones?
They're considered second line. So you'd only move to an amino acid formula if the EHCF or the hydrolyzed rice protein formula isn't tolerated, even if the initial presentation seems severe.
Got it. First EHCF or rice hydrolysate, then amino acid if needed. What about diagnosis? Differentiating IgE versus non-IgE mediated CMPA.
Yeah, the pathways are different. For IgE mediated, that's often the more immediate reaction you look at the clinical picture. Plus specific IgE blood tests or skin trick tests, pretty standard allergy workup.
Okay.
For non-IgE mediated, which is often delayed and more gut-focused, the gold standard is usually an oral food challenge. This is typically done at home after the baby's been off cow's milk protein for about 2 to 4 weeks.
At home, is that always safe?
Well, there's a key exception for typical food protein-induced enterocolitis syndrome, FPIES.
Ah, yes, FPIES. That can be quite dramatic.
Exactly. Because FPIEs can cause severe vomiting, dehydration, even shock. The challenge for FPIES should generally be done in a controlled hospital setting, not at home. That's a critical safety point.
Absolutely. Now, what about preventing CMPA in the first place? Lots of advice gets thrown around. Should moms restrict their diet during pregnancy? Probiotics.
Professor Tadinian's talk will likely emphasize what the evidence doesn't support. Currently, there isn't enough evidence to recommend restricting mom's diet during pregnancy or breastfeeding just to prevent CMPA.
Okay.
And the same goes for routinely giving probiotics, prebiotics, or synbiotics for prevention. The data just isn't strong enough yet.
So stick to the basics, but is there anything parents should be aware of maybe in those first few days after birth?
Yes, there's one specific warning highlighted, the so-called dangerous bottle.
The dangerous bottle.
It refers to supplementing a breastfed baby with standard cow's milk protein formula in the first few days of life, maybe just 1 or 2 bottles to top up. The advice is to avoid this if possible.
Why? Does that early exposure increase risk?
It seems it might. That brief early exposure could potentially sensitize the infant, increasing their risk of developing CMPA later on. So if supplementing is needed, maybe consider other options first if CMPA risk is a concern.
Interesting. Avoid the early formula supplement. But what about deliberately introducing cow's milk protein early to prevent allergy, like we hear about with peanuts?
That's the big open question right now. There's definitely research looking into whether introducing small amounts of cow's milk protein early, even in exclusively breastfed infants, might induce tolerance and prevent CMPA.
But it's not standard practice yet.
No, not yet. We need more studies to figure out the best timing, the right amount, how often. So it's an area to watch, but not a current recommendation for general practice.
Okay, that's a really helpful clarification on CMPA. Let's shift again from allergy to deficiency. Rickets. It sounds almost historical, but it's still a problem, right?
Shockingly so. Thomas Thatcher from the USA is presenting on this in the session, Paediatrics in Practice 13. Rickets from the neonate to the child. And yes, nutritional rickets is entirely preventable, yet it still causes significant harm globally.
Harm like what? What are the consequences?
We're talking hypocalcemia, which can cause seizures, bone pain, stunted growth, permanent skeletal deformities, lifelong disability, really. And the fact that it's preventable makes it, well, tragic.
We usually think of rickets as just a vitamin D problem. Is that the whole story?
That's a common simplification, but Professor Thatcher's work emphasizes it's actually an interaction. It's vitamin D deficiency and insufficient dietary calcium working together.
Both.
Yes, both. That combination leads to the impaired bone mineralization that defines rickets. You really need to address both vitamin D status and calcium intake to prevent and treat it effectively.
And geographically, where is this most prevalent?
The burden is highest in places like sub-Saharan Africa, the Middle East, and the Indian subcontinent.
Why they're specific?
It's often a mix of factors: darker skin pigmentation reducing vitamin D synthesis, cultural practices limiting sun exposure, diets low in calcium, and lack of food fortification.
And it affects immigrants too, right, if they move to less sunny regions?
Absolutely. People from these high-risk regions moving to northern or southern latitudes are at increased risk because their sun exposure drops significantly, especially during winter months. Clinicians need to be aware of that.
Now, here's something I found really interesting. the main cause actually changes depending on the child's age.
Yes, this is a vital point for practice. In the first, say, 18 months of life, vitamin D deficiency is usually the primary driver of rickets.
Okay, early infancy, vitamin D.
Right. But after that age, insufficient dietary calcium intake becomes the more significant factor. The child might be getting enough vitamin D, but if their calcium intake from weaning foods is too low, they can still develop rickets.
So the prevention and treatment strategy needs to adapt based on age.
Exactly. Eradication requires a multi-pronged approach. You need vitamin D supplements for moms and infants. You need widespread vitamin D fortification of staple foods.
And crucially,
You need strategies to ensure adequate calcium intake, especially through complementary foods for toddlers and older children. Public health messaging and potentially calcium fortification or supplementation become key for that older age group.
it really highlights the need for a life course approach. Okay, let's pivot to the endocrinology part of our theme. Neonatal hypoglycemia, that first metabolic hurdle after birth.
A critical one.
Yeah.
And Emmanuel Mott-Signoret from France will be providing the endocrinologist's view on updates on neonatal hypoglycemia in the Paediatrics in Practice 06 session.
So birth means going from a steady glucose supply via the placenta to nothing. The baby has to manage its own blood sugar immediately. What's the key physiological switch?
The main challenge is flipping the hormone balance. The glucagon-insulin ratio needs to invert more glucagon, less insulin, to allow the baby to tap into its stored fuel.
It's liver glycogen and fat reserves.
Precisely. If that hormonal switch doesn't happen smoothly, or if the baby doesn't have enough stores to begin with, hypoglycemia is a real risk.
So we can often predict who's at higher risk.
Yes, often. Think about babies with low stores preemies or infants who are small for gestational age, SGA. Or babies under stress infection, hypothermia, respiratory distress, because stress increases glucose consumption.
Right.
These babies absolutely need close blood sugar monitoring right from the start.
And what about the opposite problem? Too much insulin.
That's the other major risk category. Hyperinsulinism actively prevents the baby from mobilizing those fuel stores. We see this classically in infants born to mothers with gestational diabetes or GDM.
And large babies, macrosomic infants.
Yes, they often have transient hyperinsulinism too. Their systems are geared towards storing fuel because of the high glucose environment in utero, and that persists for a while after birth, blocking fuel release. They also need careful monitoring.
Okay, so most neonatal hypoglycemia is transient and related to these risk factors. But when should we worry that something more serious, like an underlying endocrine or metabolic disorder, is going on? What are the red flags?
You need to dig deeper. If the hypoglycemia keeps happening despite appropriate feeding, or if it happens in a baby with no known risk factors, like a healthy term baby who suddenly crashes.
Okay.
And a really big red flag is if the baby needs a huge amount of glucose infusion to stay stable. We talk about the glucose infusion rate, or GIR, if you need more than, say, 8 to 10 milligrams per kilogram per minute.
That's a lot.
It is. That high requirement strongly suggests there's an underlying problem stopping the baby from making or using its own glucose properly.
So if you see those red flags, what conditions are on the differential diagnosis list? What tests do you need?
You need to get critical samples, blood and urine, during an episode of hypoglycemia before you give glucose if possible. You're looking for things like congenital hyperinsulinism, which is a major one. Also, hormone deficiencies, problems with the pituitary gland causing hypopituitarism or adrenal insufficiency. And then the inherited metabolic disorders like fatty acid oxidation defects or glycogen storage disease type 1.
And finding the specific cause is critical, isn't it? Because the treatment varies wildly.
Absolutely.
Yeah.
Just giving glucose isn't enough if there's an underlying defect. Congenital hyperinsulinism might need specific drugs or even pancreatic surgery. Adrenal insufficiency needs hydrocortisone. Fatty acid oxidation defects require avoiding fasting and sometimes special diets.
So getting that diagnosis quickly using those critical samples is essential for preventing long-term neurological damage from recurrent low blood sugar.
Exactly. It allows for targeted life-saving treatment.
Wow. Okay, this has been a really comprehensive preview. We've gone from the genetics of obesity through specific allergy management like CMPA, tackled global deficiencies like rickets, and landed on acute neonatal endocrine emergencies like hypoglycemia. It really shows the scope of this nutrition, obesity, and endocrinology theme at EAPS 2025.
It does. And you can see the connections, can't you? How understanding fundamental nutrition impacts chronic disease, acute care, global health. It all ties together. The research is moving fast, And these talks promise to translate that into practical knowledge.
It really feels like integrating these different viewpoints, the genetic, the dietary, the acute care, the public health perspective, is going to be essential for advancing pediatric practice.
Couldn't agree more. It's about seeing the whole picture.
Well, we hope this preview has given you a valuable taste of what's to come. We encourage you to join the discussions, whether in person or online.
That's right. The EAPS 2025 Congress is coming up soon. October 18th to the 20th in beautiful Lisbon, Portugal, and also accessible online.
We wish you all the best until our next episode, and we hope to see many of you at the Congress.